Yeah, hi. Very good evening, doctors, for joining today's eyesight scientific meeting from Bayer Ilia. It's great to have you today's evening. Just I would like to introduce today's moderator for the session, Dr. Lohit sir. Dr. Lohit Rambarki sir is completed his post graduation and vitreoretinal residency at AIMS. He was working as consultant at AIMS New Delhi, and currently HOD Retina Department at Vishaka Eye Hospital from past 5 years. Sir is having sound scientific knowledge, and I actively participates in all the scientific meetings from from Visakhapatnam. With this, I would like to hand over the floor to Lohit sir to take it forward. Sir, Lohit sir, please take the meeting forward, sir. Thank you.
Good evening, everyone. Thank you, Srinivas Garu, and Alia team Bayer, for giving this opportunity. Today we have two beautiful topics by two beautiful speakers. First, we goes with Dr. Praveen sir. He co-founder of the Akshay Eye Hospital, Superficiality Eye Hospital. He did his post-graduation and surgical retina fellowship from the AIMS New Delhi. Now he is he is heading retina department in Akshay Superficiality Eye Hospital. So first we'll start with the presentation with Praveen, Dr. Praveen. Please go ahead.
Yes, thank you, Dr. Lohit, for your warm introduction. Once again. Is my presentation visible?
Yes, sir.
Yeah.
You please minimize that, sir.
Second.
Pull it aside, sir.
Once again.
Pull it aside, sir. The
ప్రవీణ్
right
సార్
side.
స్వైప్
Right side.
చేసేస్తే కంప్లీట్ గా వెళ్ళిపోతుంది.
Ante, yes, sir.
Right. So, good evening and a very warm welcome to everyone who is attending the webinar. So today I am going to speak about evaluating the need for change, evidence and insights on anti-VEGF therapies. So disclaimers and so basically the current management, if we talk about neovascular AMD, the current anti-VEGF treatment of choice in wet AMD is bevacizumab, as earlier started with bevacizumab, later moved on to ranibizumab, followed by aflibercept and brolucizumab and faricimab. Although there is no cure for these diseases, timely treatment can help in achieve the neovascular AMD treatment goals of drying affected eyes. By mainly what they will do, they'll inhibit the new blood vessels that will leak the blood and fluid, improving the visual acuity over periods. So, however, in real world settings, significant gaps and challenges are there, which are posing to be a barriers in achieving those goals. So, what are those challenges? So, there are significant inter-individual differences in response to an anti-VEGF agent and availability of multiple anti-VEGF agents with different molecular configurations. These are the two main challenges to decide what injection to be given to any patient or how the patient responds to a particular agent. So the response to anti-VEGF therapy have been found to be dependent on a variety of factors like patient's age, lesion characteristics, duration of the lesion, baseline visual acuity, and the presence of particular genotype risk alleles. So there is currently no consensus as to how to classify optimal response or lack of it with these therapies. So how will we define response to anti-VEGF? So there is something called primary response and secondary response. Primary response after we give the first injection, 1 month following the last loading dose, like now currently followed regimen is a 3 loading doses, right? So 1 month from the last loading dose, we call it as primary response. So secondary response is any time after the fourth visit. So secondary responses do not mirror and cannot be predicted from the primary phase. So there is a ceiling effect that can negate the currently used functional metrics, such as greater than 5 letters improvement or when the baseline vision is good. So when the baseline vision is good, we can't actually determine if the patient is having 6/9 parts or 6/6 parts. We can't actually use that as a what you call functional metric to determine the effect of the drug. So what we do exactly is we study the macular morphology, which is assessed with the help of OCT. And even ICG angiography is also useful, but it can be reserved for cases with polychoroid PCV or a RAP, where the response is suboptimal. So the response after primary phase. So what we call, if we see, there are two types of responses: morphological and functional response. So anatomically, we can see how do we define as good response. If there are absence of subretinal fluid or interretinal fluid or IRC or a reduction of central retinal thickness greater than 75% of the baseline values, we call that response as good response, good anatomical response. And talking about functional response, if there is improvement in vision greater than 5 letters from the baseline, we call it as good response. So anywhere in between 25 to 75% of the reduction on the central retinal thickness, we call it as partial response, and less than 25% reduction in central retinal thickness or persistence of these all the above mentioned SRF, IRF, and IRC, we call it as poor response. So similarly, it will correlate with the functional response. So these are all the things that we need to actually look fit the patient into, whether it is a patient is having good response, partial response, poor response, or a non-response. So there are so many new anti-VEGF that are being spoken into. How much is it worth? So we recently saw a new anti-VEGF which has been approved by the US FDA called faricimab, which acts on a different pathway other than VEGF. It also acts on angiopoietin 2. So there are studies. So 92% of the patients who switch from aflibercept to faricimab discontinue treatment due to insufficient efficacy. So if you can see this study from Kotaoka et al., 130 eyes which are previously treated from aflibercept, they switched to faricimab. And almost we can see from this slide, you can see 60 from baseline to month 6, about 60% of people discontinued faricimab treatment, and out of which 92% discontinued due to insufficient efficacy of faricimab, and 73% switched back to aflibercept. And the main takeaway point here is majority of the patients did not extend beyond Q8 interval. It was the same similar results were observed from another study by Kishi et al., where 71% who switched from aflibercept to faricimab remained on a less than Q8 intervals from the baseline. So after 3 faricimab injections, there is no change in visual acuity. There are mixed outcomes in anatomic parameters. And the majority of the patients, like greater than 70% of the patients, has a treatment interval less than 8 weeks. So in another study by Hara et al., after 3 loading doses, significantly better visual outcomes were observed with aflibercept compared with the faricimab. So after 3, the mean CRT markedly improved from baseline to month 3 in both aflibercept and faricimab groups. So this is another study by Bailey C. et al., where the study showed the real-world study with faricimab and DME, which showed limited visual gains. Prior, they were given some other anti-VEGF, out of which 72% were previously treated eyes were switched from aflibercept. So you can see in this graph, after second injection, after third injection of faricimab, after fourth injection of faricimab. And also, there is very limited improvement on IVT intervals in DME patients. This is also by Bailey C. et al. If you can see this pie diagram, 47%, 47.6% of the people are like having less than Q8 intervals, and 46% are between Q8 to Q12 intervals, and greater than just 6.5% are sustained for greater than Q12 intervals. So despite multiple faricimab injections, majority of the patients are in Q8 less than Q8 intervals. So this is evaluating effects. This is another study published in JAMA evaluating effects of switching anti-VEGF drugs for ARMD and macular edema. So basically, we all treat in such a way that we give initial loading doses. For example, if we have given three aflibercept loading doses, if the response is poor, we immediately switch. So the main question is in studies of effects of switching anti-VEGFs after poor initial response, can it be assumed that there will be no further future improvement if there is no switching? Like if we don't switch and if we keep on continuing the giving the aflibercept, what can we assume? Like can we be 100% sure that will there be poor response? So in eyes meeting criteria for switching, but maintained on still on original agents, improvements in visual acuity and retinal thickness were also observed in some studies. That means whenever we are doing any studies where we are comparing the molecules like aflibercept and faricimab, a control group should also be maintained where the original agent, despite of no poor response to the original agent, a control group should also be maintained where continuing the same primary drug which was being given. Only then it will make some sense to actually confirm the fact that switching from aflibercept to faricimab will actually prove some difference. So, could targeting additional pathways beyond VEGF be beneficial? So, additional pathways, what I'm speaking is about angiopoietin 2. So, even Bayer has done a study, aflibercept 2 milligrams with nesvacumab, that is actually inhibiting angiopoietin 2. And additional pathways, as we are talking about faricimab, which is inhibiting the angiopoietin 2, and brolucizumab and ranibizumab, anyways, they inhibit the VEGF-A pathway. So if we talk mainly about aflibercept plus nesvacumab, they have done some studies in Ruby and Onyx trial. They targeted both angiopoietin 2 and VEGF-R pathways, but they did not see any significant additional improvements in vision. That is the reason they have stuck with only aflibercept monotherapy rather than adding the nesvacumab. That has been studied in Onyx in neovascular AMD and Ruby study in DME. Whereas uh, faricimab, several different approaches have been attempted. So faricimab in TENAYA or Lucerne trial, which were the main trials for faricimab was quoted as it is non-inferior to aflibercept 2 mg for mean BCVA change. The non and in Avenue, there is another clinical trial where they compared effect of ranibizumab and faricimab. It has also been described that ranibizumab itself also provides a similar effect to inhibiting the angiopoietin 2 pathways. So that is the reason they have done this comparative study where they have compared both ranibizumab and faricimab. So these data suggest that anti-VEGF monotherapy neutralizes angiopoietin 2 to levels comparable to that achieved when directly targeting angiopoietin 2. So the study basically says that there is no requirement for an additional pathway inhibitor where ranibizumab itself is inhibiting the angiopoietin 2, suggesting that the anti-angiopoietin 2 mechanism of action of faricimab may provide no additional benefit over anti-VEGF monotherapy. So the VEGF binding arm of faricimab is ranibizumab, and role of angiopoietin 2 has not been established to show clinical effectiveness. So even the FDA approval stated that the VEGF antigen binding fragment is identical to ranibizumab, the FAB fragment, and the contribution of angiopoietin 2 inhibition to the treatment and effect of clinical response for neovascular AMD and DME is yet to be established. So preclinical data suggests that VEGF is a key driver of angiopoietin 2 production, and anti-VEGF agents can block VEGF-R driven angiopoietin 2 generation. So basically, the results of this study support the hypothesis that angiopoietin 2 may be expressed secondary to primary insults to retinal vasculature by the VEGF. And direct inhibition of angiopoietin 2 may not be clinically relevant as this is currently provided by anti-VEGF treatment alone. So there is no point in actually adding another angiopoietin 2 inhibitor. So we all know VEGF-R pathway remains the master regulator in the retinal disease. So VEGF pathway is a master regulator. As we all know this mechanism, VEGF-A, it will act where it will cause inflammation, neovascularization, retinal vascular leakage, and macular edema. And also aflibercept inhibits not only VEGF family but also the PIGF. Especially both VEGF-A and PIGF are the key components of inflammatory response cascade. So aflibercept is the only widely approved agent that blocks all VEGF-R1 ligands and the key VEGF-R2 ligand. So other and approved anti-VEGF agents are brolucizumab, faricimab, and ranibizumab. They all inhibit the VEGF-A. So despite complete inhibition of VEGF-A, PIGF-mediated effects can still be activated through VEGF-R1 signaling. So that is the reason aflibercept, what it will do, it will not only inhibit the VEGF, entire family of VEGF, but it additionally targets the key ligand of PIGF, thus leading to prevention of this macular edema. So to summarize, with aflibercept 2 mg already targeting key ligands of the master regulated VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. Increasing the molar dose of an anti-VEGF agent may have the potential to offer patients more through extended VEGF suppression. So basically from 2 mg, what aflibercept is trying to, what a Bayer is trying to do is it is trying to increase the molar concentration of the aflibercept, which is currently 2 mg. That might lead to a more sustained stay in the eye and which might lead to more durability in the coming days. So have we maximized outcomes for our patients or can we go further with the disease control? That is what we should see. So aflibercept 2 mg has set the bar high for treatment of exudative retinal disease with novel agents yet to surpass its standard of care. So it, as spoken, aflibercept targets the key ligands of VEGF pathway, which is the master regulator of pathological angiogenesis. Targeting other pathways has not resulted in improved patient outcomes beyond aflibercept. So also the data from the latest studies, the PULSAR and PHOTON suggest that aflibercept 8 mg has the potential for greater and longer lasting effect of control underlying disease compared with aflibercept 2 mg with sustained disease control. So yeah, so we're done with the presentation. Any questions?
Lohit sir, over to you. Hello, Lohit sir.
Hello,
Yes, sir.
am I audible?
Yes, sir.
Yes.
Now you are audible.
Thank you, Dr. Praveen, for your detailed and explanation. Detailed presentation and good explanation for even as the many postgraduates also participated in this presentation.
Yes.
And we have a couple of questions regarding the real world scenario between the aflibercept with compared with the faricimab. Another thing is we have we have treated many naive cases of DME or many retinal diseases with both aflibercept and faricimab. What is your experience?
So basically, initially when faricimab was introduced, I usually used to treat patients who are actually non-responsive to aflibercept. So, as keeping aside the economic scenario, because economically is also it is quite high, but still some patients who are affordable, I switched from aflibercept to Vabysmo. So they didn't give the wow effect, but still they showed a decent response, which is similar to aflibercept. That is what I have observed. It's not like completely in cases which are completely resistant to aflibercept. Vabysmo has proven to be some outstanding. It's nothing like that, but it has given equal results in both the drugs, both aflibercept and Vabysmo. And coming to treatment naive cases, recently I've started giving some cases to for the efficacy of Vabysmo in treatment naive cases also. It is also providing the similar efficacy compared to aflibercept. There is no big major difference between aflibercept and Vabysmo as of now. I feel there is no added advantage, but still, since Vabysmo is recently launched, it has got a long way to go to check for the durability and all. And with aflibercept now coming with 8 mg dose, we need to have those comparison trials between 8 mg aflibercept and Vabysmo to actually see which drug is more durable compared to each other. So that is what we need to wait for. So
Thank you. Thank you, Ravi.
thank you.
So next we can move on to next speaker, Dr. Gunshravan. He will be discussing about the aflibercept also. Dr. Gunshravan has completed the ophthalmology from Government Hospital Tankuru and post graduation from the Arvind Hospital, Pondicherry. He has been working in Vishaka Hospital for last few months. So he will be presenting case presentation in the next couple minutes.
Thank you, sir. Thank you for the one thing. Thank you, Bears Company. Am I audible? Are my slides are visible?
Yes, sir.
Yeah. Good morning, everyone. Today, we'll be seeing the evaluating of anti-VEGF drug molecules and their characteristics and their impact on the treatment success. As already Praveen sir have compared about the efficacy of both the drugs, we will be dealing with all the anti-VEGFs and their efficacies. So this is the disclaimer. So if any drug which comes into the market, first we have to see whether it is FDA approved or not in your country or in other countries, to what all diseases it's been approved. So this is a normal page of an FDA page where you can go to the food and FDA page and you can search about the drug. And do you know what all the studies or the trials on which phase of the trial is the drug is there at present in that market, and what all the positive results or negative results the drug has been updated into the FDA page that you can clearly see via this website. So any new launched or an old drug, you can go through via this one. So coming to the basic pathophysiology, everyone knows in diabetes, because of the impaired vascular function and hypoxia, VEGF and placental growth factors has been released, which indeed leads to neovascularization, vessel leakage, and inflammatory vessel leakage. So there are two domains. Coming to the aflibercept. Aflibercept, Eylea, mostly everyone known as, it's a multi-targeted therapeutical fusion protein. It acts on multiple targets like VEGF-A, B, placental growth factor, and it also acts as a decoy receptor by trapping the galactin-1. So mostly it acts on VEGF ligands receptor 1 and 2 by domain 1 and 3 and decreases the inflammation, neovascularization, and retinal vascular leakage and edema. So each molecule have different binding affinities, potencies, half-life, clinical targets, and molar doses. So let's discuss in detail. Coming to the binding affinity, there is a KD value for each drug. KD means dissociation constant. So lower the dissociation constant, the higher is the affinity. From the different head-to-head studies where we can see aflibercept having low KD value. The VEGF receptors in the body. Whereas if you see faricimab is not having or not documented any of the KD values or dissociation constant. Razumab and brolizumab, you can see 21 and 1.3. So aflibercept was found to have a statistically higher VEGF binding affinity than brolucizumab or razumab. Similarly, when you compare the potency of the required concentration, here you will see aflibercept is having a 2.42 value, which is the inhibitory concentration. This inhibitory concentration of the faricimab is not documented anywhere in the whole of its presentation. Whereas we are having a 2.42 value of inhibitory concentration of aflibercept, which indeed shows the highest or most potent VEGF available till now. Coming to the half-life. When you see half-life, you can see the amount of the drug which is present in the human body. So compared to all the drugs, aflibercept, you can see 9.1 to 11 days inside the eye after injecting. So if the more availability of the drug for the more time in the body leads to the better action against the diseases via the blocking the ligands. Next, coming to the binding target. So you can see razumab or brolucizumab, which targets VEGF-A, whereas faricimab, you can go for VEGF-A and Ang2 dual target. Whereas our aflibercept has previously discussed, it affects or it targets VEGF-A, B, placental growth factor, and it also acts on galactin-1. So aflibercept, when you can see the main thing here, what we are discussing is in DME patients, when after injection of aflibercept, we have checked the VEGF concentration in the aqueous humor. So there is an high VEGF levels are up to 61% high in DME patients, and placental growth factors also 19 times more. After injection, baseline 1 month, 2 months, you can show drastic and significant reduction in both VEGF and placental growth factors. Now, additional targetings, whether any efficiency or not, you have to see. Angiogenic factors play a crucial role in development of edema, retinal vascular permeability, inflammation, and neovascularization and vessel stability. Here, if you see, you can say clearly the VEGF-A mainly leads to vascular leakage, inflammation, pathological neovascularization, leading to macular edema. And Ang2 receptors, here coming to the basic knowledge of Ti receptors or tyrosine kinase receptors. Ang1 basically it attaches to tyrosine kinase receptor. When it bound to one, Ang1, I'm saying about Ang1, it leads to the cell survival, reduces inflammation. Blood vessels will be in a quiescent stage, and it is structurally makes the blood vessel intact. Whereas this Ang2, which is there, that one is a competitive antagonist for tyrosine kinase receptors. This Ang2 will stimulate the tyrosine kinase receptors and causes proliferation of endothelial cells, migration, survival, and inflammation. So tyrosine kinase, that's why these new drugs or the old drug or Eylea, which all are targeting Ang2, they want to at least get a small chance to still more be so much effective compared to only targeting VEGF-A. Is there any chance? That is the main thing why they are speaking, everyone is speaking about this Ang2. So basically what they observed is when we are having high VEGFs, Ang2 is also more, which leads to the destabilization of the blood vessels. While in low VEGF states, the Ang2 is also drastically low. Even if he doesn't block it also, if VEGF is low, Ang2 is becoming low, directly proportional to the VEGF states in the body. So, however, our Eylea is or aflibercept is most potent binder of VEGF compared to any other available agents. So, because of the potency, VEGF is decreasing. Automatically, Ang2 is also effectively decreased. So, Bayer in 2000, mostly 13, like the 2013, you can see Bayer company. What they have done is they have introduced a new molecule, nesvacumab. So coming to the dissociation constant of faricimab, you can see 22,000, whereas nesvacumab is for 24 only. For Ang2 pathway, they want to block that one. So they have introduced a new drug called nesvacumab, and they have done few studies. That is, these are the two sister studies, RUBY and ONYX. In these studies, it is basically, the study is nothing but here, these are the two parallel studies which has randomization has been done in a double masked phase 2 clinical trials. Here they have compared nesvacumab and aflibercept and normal plain. So they have introduced 3 mg and 2 mg, 6 mg, 2 mg, and only plain 2 mg aflibercept in 3 groups, and they have seen the difference. So in all the groups, you can see there is an equal reduction. There is no, because of adding nesvacumab, there is no drastical betterment of visual acuity. So they are maintaining the equal potency. That is what these studies meant. So, directly they are conveying that even though we are having a better drug nesvacumab, which can potently block Ang2 to the maximum extent, we are getting the same results of, or same best corrected visual acuity, where the aflibercept blocks the VEGF thing. And there are another studies done by faricimab, has already discussed, yosemite, TRAIN for DME, and TENIA and LUCERNE for ARMD. These are the phase 3 clinical trials. So they have basically divided those two into double masked RCTs, and they have seen. So there is, here what you see means the studies which have been done, those are unbalanced. So the additional targeting doesn't convey any clinical benefit while comparing to the plain aflibercept. So this is clearly shows that addition of Ang2, the potency or that extra edge of Ang2 blocking doesn't produce any more clinical benefit. And another one is the study which is done by faricimab, by Roche people. It's a phase 2 RCT, that is Avenue study. They have compared with Razimab. When they have compared with ranibizumab, mostly Lucentis, here you can see the faricimab, first of all, it failed to meet the primary endpoint. Razimab show its superiority because it is blocking VEGF-A. So the Ang2 inhibition was similarly between the agents, because as already you know the pathophysiology, if VEGF decreases, Ang2 automatically decreases. And no additional benefit. You can see faricimab is having no additional benefit over anti-VEGF monotherapy. And another one here, aflibercept, when it is compared with brolucizumab and ranibizumab, the results of the study show the hypothesis that Ang2 may be expressed secondary to primary insults to retinal vasculature by VEGF. And direct inhibition of Ang2 may not be clinically relevant, as this is currently provided by anti-VEGF treatment alone. Sorry, 1 second. So another, again, you can see all the different molecules over here, where you can see the 4 drugs with different dissociation constant and inhibitory concentration, half-life, and potency. And aflibercept and nesvacumab, which affects or which targets different pathways, including Ang2, faricimab with 6 mg. So finally, a small meta-analytic study, consensus statement, where initially to say that the anti-VEGFs are now becoming the first line of treatment for central involving DME. Previous studies used to say laser treatment is the first choice, but now VEGFs are becoming, and corticosteroids are like second line or the second choice of level compared to the laser therapy. And you can see these are not trials, but these are the experiences of the hospitals with Eylea or aflibercept. In first year, second year, third year, fourth year, different hospitals like Moorfields and Marimoto, in different diseases like AMD or neovascular AMD, PCV, and DME. The visual gain is maintained and it is visual gains achieved, and the treatment burden is also reduced. No need of like monthly injections. It's like quarterly. They are decreasing. They are going even for 6 months also. That much period of dryness you are getting in the macula. So coming to the summary, aflibercept targets where VEGF and placental growth factor therapy downstream signaling the ligands VEGF1 and 2, which is the master regulator of the pathological angiogenesis. To date, both preclinical and clinical data suggest that is there is no additional benefit of targeting alternatives. And separate independent studies of aflibercept has a greater binding affinities for VEGF-A and a greater potency and longer half-life than other available anti-VEGF agents. These factors contribute to strong VEGF suppression seen with aflibercept. Thank you all.
Thank you, Dr. Guru, for the again. Both speakers have very good explanation on the presentations, as well as the detailed presentation. As I mentioned, postgraduates are also there present in this presentation. Now what we are discussing with aflibercept is now the clinical scenario of the anti-VEGF molecules are more about high molecular weight. Nowadays, aflibercept 2 milligram, faricimab and brolucizumab are 6 milligrams. So high molecular weights, the aflibercept is competing with the high molecular weight, and its results are safe, efficient, and efficacy in every aspect. Aflibercept is doing better than the faricimab and other molecules. So, a couple of questions for the Dr. Guru. In the what you mentioned of the FDA approval, what is the FDA approved status of the aflibercept in various diseases, and also what is the real world scenario of aflibercept in your clinical experience regarding the FDA status approval and other in terms of safety, efficacy? Please, sir.
Yes. Sir, coming to aflibercept, here we can see that aflibercept, which is in India and in FDA, is approved for wet AMD and diabetic macular edema. So in real world scenarios, while compared to any other drugs, razumab or faricimab, first initially we used to use aflibercept as a second line of therapy. Initially, if the disease doesn't decrease with razumab or any other Avastin or something, we used to go for aflibercept because based on mostly patients' affordability. Then later now, due to the conditions or chronicity, sometimes aflibercept gives the best result compared to any other newer drugs like faricimab. Also, aflibercept is doing well in case of nail cases, according to my experience. And patient is having a long-term relief compared to other drugs. Other drugs, at least the recurrence is there after 3 months minimum, like not the dryness is not maintained. Whereas for Eylea, you can see a better dryness of the retina after minimal doses. In some patients I have seen for 1 to 2 doses only, they're getting that clinically dry state and visual acuity has been maintained throughout. So that's it, sir.
We will take a couple of questions from the audience also. If anyone has any doubts, you can raise or you can message. Meanwhile, regarding the aflibercept and other molecules, aflibercept, the previous cost was around 50,000. When it was after from this year, from April, the price has been reduced. But still competing with the other compared to molecules like faricimab and brolucizumab. It's aflibercept has all FDA approvals with regarding the DME and AMD also, and we are previously we are using for vein occlusions also, which other molecules are lacking their approvals, and so when we are comparing with other molecules, aflibercept is very cost effective. Even patient support program with other molecules like faricimab or brolucizumab without patient support program, aflibercept cost is very cost effective. It is around 28,000 to the patient. So with the lower cost, we can have a good efficacy, safety profile, and less number of injections with if you compare in a total year with greater durability and less frequent injections. So thank you, and thank you, Dr. Guru. If there are no questions, we can give over to Mr. Srinivas Garu.
Yes, sir. I'm checking the chat box, sir, if any questions were there. No, sir. Chat box also not having any question. Meanwhile, we'll conclude in 2-3 more minutes, sir. Meanwhile, if any question is there to Praveen, sir, or any otherwise any comments from Praveen, sir.
Yeah, actually, as Dr. Lohit rightly mentioned, compared to now after the price has been slashed, I think it will become more affordable to the patient to get a good drug. Previously, it used to have patient support program, but now they are giving it a flat price. I think that's a very good move from Aflibercept, from Bayer, so that more patients will afford, and in directly in treatment naive cases, it can be actually considered as a first line choice, considering the price factor also, which was previously a little bit troublesome, but right now I think it's a good thing. And efficacy wise, it's anyways it is similar to Vabysmo, and now with upcoming 8 milligrams dose, I think it should be even more effective compared to Vabysmo. The main thing is if we can improve the durability of the drug, and if we can have the good drying effect for longer duration of time, I think the drug will sustain more in the market compared with the other drugs. So waiting for Aflibercept 8 mg. When is it getting launched? Aflibercept 8 mg, Srinivas?
Sir, it is under approval process, sir. Positively, we are expecting by the time of VRSA, sir, but yet to get the official confirmation, sir. I'll personally communicate to you, sir, the moment we get the approval. But most positively towards by this year end or by VRSA time, we are expecting, sir.
Will the patient support program be available for that 8 mg?
Actually, details were not yet disclosed, sir. The moment we get the approval,
Okay.
we will design. Definitely, one thing is for sure, sir. Being Bayer is a patient-oriented company, definitely it will be reachable to the patients, sir. Indian patients.
Okay.
Yes.
Thank you very much.
Thank you, sir. Thank you. Lohit, sir, if there are no other comments, we can good to close
Yes, we
the.
can close by saying that many biosimilars are coming with the Aflibercept, but recently we had a very even bad event with the biosimilars as per the VRS as mentioned. So anyway, innovative molecule is innovative molecule. So with the safety profile and effectiveness, still Aflibercept holds a good position. Thank you.
Yes, sir. Thank you so much, sir. Definitely, this meeting is actually a scientifically driven meeting, and there were a lot more insights has been discussed across the meeting, sir. Wonderful moderation by Dr. Lohit, sir, and great presentation by Dr. Praveen, sir, and Dr. Guru Sevan, sir. But looking forward to have such more great scientific conversations in future as well, sir. Thank you so much for your active participation, sir. And I would like to thank all the audience and all the doctors who spare their evening time to for this educational and scientific meeting. Thank you so much once again. Thank you so much, sir.
Thank you very much.
Thank
Tech
you.
team, you can conclude the meeting. Thank you, sir.
Okay, sir, we are concluding the meeting now.